Let's talk about how different the pharmacy practice is in the UK from where I'm coming from. Hi, my name is Favor and I film about faith and lifestyle and everything in between. In today's video, I'm going to be talking about some differences that I experienced when I started working in a UK pharmacy. The first difference that I'm going to talk about, of course, is the structure of the workforce. This was definitely very new to me. So I'd worked in a community pharmacy in Nigeria at some point, and I've also worked in a community pharmacy in the UK at some point. And what I would say is the difference in the workforce. The first thing is that, in every standard pharmacy, you should have a responsible pharmacist. That also applies in Nigeria. But the workforce is typically pharmacist led. In other words, at the time that I worked in a pharmacy when I was in Nigeria, I think there were just one or two technicians that worked at the pharmacy. Every other person was a pharmacist, and then they also had pharmacy interns as well. So imagine my shock when I moved to a UK pharmacy and I see that there's just one pharmacist that has to be on the premises, and that's all that they have. That was so new to me. There's a lot more pharmacy assistants, pharmacy dispensers, counter assistants. Like, the roles are quite diverse, and they only really need one pharmacist to be on the premises at a time. And of course, it's less money compared to having to pay different pharmacists and paying a pharmacist and other supporting staff. Number two is the use of bio letters on medication. For the longest time, I didn't even know what this meant. I just knew that there were dotted lines on medications, and it took a while until one random conversation where I realized, oh, these are not just random dots, they actually mean something. They are letters. I would add a picture of what the bio letters look like, and they are basically to help people who are visually impaired recognize what medications they are holding. And I think that's so good. There's quite a lot of intention that I see around trying to include people who have some form of disability, and I think that is great. Number three is seeing that the over-the-counter medications that we use in Nigeria are quite different from the over-the-counter medications that are here. First of all, of course, our go-to medicines are different. There are ways that they are similar, but there are some medications that are quite different. I don't know if I've seen a prescription for ciproflox. I've seen tablets in this country. I don't remember if I've seen any, so that's to tell you what we use most frequently kind of differs across the countries. But let me tell you this. Cocodamol is an over-the-counter medication, and I could not and have not gotten over that. In Nigeria, cocodamol is a controlled medication, and that goes into the CD register whenever you dispense it. But here, there are different strengths of cocodamol, and so the lowest strength is actually sold over the counter without a prescription. I was quite shocked. And guess what? Diclofenac tablet is not an over-the-counter medication, and I haven't seen a prescription for it. Maybe once, if any, but I actually haven't. So, like, those differences actually shocked me. I'm like, cocodamol is an over-the-counter medication and diclofenac tablet isn't. But yeah, there's just some sort of difference in the regulation of medicines here. There's also something interesting that I noticed. I saw that prescribers typically, sometimes, I also kind of find it annoying, but this is not to judge anybody. A medication comes in 100 milligram, and it also comes in 50 milligram. What you want is for a patient to take this medication 100 milligram twice a day. Instead of prescribing 100 milligram and saying take one twice a day, they will prescribe the 50 milligram and say take two twice a day. I'm like, this doesn't encourage patient compliance. If you can make it easier for the patient to take this medication, why not make it easier? Who will swallow one tablet instead of two if they had the choice? So sometimes it kind of amazes me how some prescriptions are done. I believe there are reasons why some people lean towards certain styles, or sometimes maybe they really just don't know. I don't know. But it actually amuses me every time I see stuff like that. I also realize that there is more, we embrace combination therapies a lot more, in Nigeria. What I mean is, for example, a patient who is managing severe diabetes is most likely on more than one medication for that condition, right? And I see medications that exist combining two different medications together, and so the patient just has to take one medication, technically one medication, but they're taking two things because those two things have become one medication, which, like I said, encourages patient compliance. But here I don't really see much of combination therapies as much. But yeah, just some sort of difference. There's another thing that I also realize is that not every pharmacist has a prescriber license. So there's such a thing as a prescriber license as as a pharmacist generally. So some pharmacists can prescribe, and there are medications that come in, prescriptions that come in, and you are able to change them. But if you don't have a prescriber license, you might be limited in being able to make certain kinds of adjustments. When a prescription comes in for amlodipine 10 milligram, now what we would typically do in a pharmacy, if I were in Nigeria or like a hospital pharmacy, it's not out of place to say, oh, the 10 milligram is unavailable at the moment, you need this medication urgently, we have the 5 milligram. If you take two of that, that's equivalent to 10 milligram. Not a big deal in any way, shape, or form. But here it is a big deal. They follow prescriptions to the T. So you really have to do what the doctor has said. And of course, nobody wants issues. All these things were quite new to me and took some adjusting to understand that this is a new system. This is a different system. If tablets are prescribed, you cannot just change it to capsules. You can't. There's just, I mean, sometimes the patients are okay with it, and there are procedures to follow to make such changes, but you cannot just say, oh, it's just the same thing. If it's tablets and I give capsules, it doesn't matter. Okay. Yeah, so something else is that the bulk of the work in a community pharmacy comes from patients' prescriptions, not even people that are coming in to just buy medications. So the work kind of is done even before the patient comes in, because everything is on a computerized system. Everything is on a central system. They've sent your medications ahead to the pharmacy long before you get there. Well, sometimes not long before, but they sent your medications to the pharmacy before you've even gotten there. And our aim is to make sure that the medications are available, done, and prepared for you way before you come. So the bulk of the work is done before you come into the pharmacy. There are people who still come in with physical prescriptions, but of course, a larger number of people already have their medications sent through from their GPs before they come into the pharmacy. Yeah, those are some differences that I had to get used to, or things that were new to me when I started working in a pharmacy setting in the UK. Let me know what you think about this video, or if there's any topic you would like me to talk about. Thank you for watching. Like this video, share, and subscribe. Bye.